good afternoon, or good morning, depending on your location. And welcome to the Leveraging Social Environment in the Prevention of Opioid Use Disorder. We're excited to have the opportunity to share and engage with you as part of an ongoing collaboration between RTI International and the RX Summit team. We've designed today's webinar as a bidirectional learning opportunity. And what do I mean by that? We hope to share information that you find new, interesting, and hopefully thought-provoking. But we also hope to learn from you through your questions and responses to ours. My name is Philip Graham, and I direct RTI's Center on Social Determinants, Risk Behaviors, and Prevention Science. I also serve as a principal investigator for NIDA's HEAL Prevention Coordinating Center, which supports the work of the HEAL Prevention Initiative. You'll learn more about the center later during this webinar. Today, you will hear from three of my colleagues and research partners who also staff the HEAL Prevention Coordinating Center, including Dr. Jessica Kantz, who supports the Implementation Science Work Group and who led our first systematic review, followed by Dr. Ty Ridenour, who also serves as the MPI for the Coordinating Center and leads the Methods Core. Then followed by Dr. Elvira Ellick, who serves as the Project Director for the Coordinating Center. They each will introduce themselves prior to their respective presentations. And last but not least, Dr. Laurie Palin, not pictured here, will serve as our Q&A moderator. But before I continue, I need to do some quick housekeeping. Today's webinar is sponsored by RTI International in collaboration with the Psychiatric and Behavioral Health Learning Network. And for those who are interested in providing questions, you can submit a question at the bottom left of your screen at any time during today's webinar or presentations. All questions will be answered during the last 10 minutes of the program. For resources, you can find a PDF of the presentation and additional resources under the headshot image located to the left of the screen. For additional assistance, please email Ms. Melissa Bangura at the email address listed here. This slide provides information and guidance needed to ensure you get your CEU credits. The most important guidance, please do not leave the console. You will be automatically redirected to an evaluation landing page at the end of this webinar. After completion of the evaluation, you'll be able to download or print your certificate. Your credit is only offered for this live broadcast. Now back to today's webinar. The opioid epidemic continues to impact the lives of individuals and communities in which they live, despite a global pandemic. But today, I want to specifically talk about its impact on youth and young adults. In 2019, among 16 to 25-year-olds, more than 500,000 misused pain relievers in the past month, and more than 2 million misused pain relievers in the past year. In response, the broad substance use field has focused most of its efforts to treat addiction and prevent overdoses and deaths, but not necessarily to prevent misuse or escalation to OUD. This is illustrated where the research has occurred. This slide makes the point. As of October 16, 2020, articles focused on opioid treatment significantly dwarf those focused on opioid prevention, and many of these listed as opioid prevention are more related to preventing overdoses and deaths. And this is why we wanted to present today's webinar. Treatment and harm reduction strategies are needed and necessary to address the opioid epidemic. But we fundamentally believe that we will not significantly bend this curve until we look upstream and figure out how to prevent misuse and reduce the number of individuals exposed to opioid use. This includes understanding the role of social environment and the connections within them. So today's webinar is intended to address the following three objectives. First, recognize the links between opioid use and social connections. Share examples of opioid prevention research projects that leverage social environment and systems, and recognize unique challenges and related adaptations for COVID-19. I'd now like to turn the presentation over to Dr. Jessica Kantz. Jessica?
Hello, everyone. I'm Dr. Jessica Duncan-Kantz, and today I will be talking with you about what we know about the associations between social connection and opioid misuse, both from a theoretical perspective and based on our ongoing systematic review of the literature. The past 8 months have highlighted the importance of social connection as a critical component of individual and community life. Speaking broadly, social connection conceptualizes the subjective experiences and salience of belongingness that individuals feel at an interpersonal, community, and societal level. When healthy social connections are cultivated, research suggests individuals are more likely to enjoy longer, happier, and more prosperous lives. The more individuals connect with other people, the more they trust them. And greater trust leads to increased collaboration towards shared goals, furthering societal development at large. But how can we operationalize social connection in our research and practice? Existing literature lacks consensus in defining social connection. Most researchers tend to either use the term social connection as an umbrella term for concepts related to social engagement, networks, and isolation, or to focus on one of these concepts to best meet their needs. There are many theories as to how social connection impacts individual behavior. The social ecological model, or SEM, can serve as a useful framework to organize these theories and the various constructs of social connection. The social ecological model is a conceptual framework adapted in the late 1980s by the U.S. Centers for Disease Control and Prevention to better understand the multidimensional factors that influence health behaviors, such as opioid misuse. Intrapersonal factors are internal characteristics of the individual of focus and can include beliefs that exist within the individual about social connection, such as loneliness, perceived rejection, and perceptions of social isolation. The next level, interpersonal measures of social connection, are factors associated with relationships between the individual and family or friends, such as perceived social support, quality and content of social networks, connections to family or significant others, and connections to pro-social agents such as teachers or caseworkers. Organizational and community measures of social connection can be thought of as factors associated with relationships between the individual and organizations, or perceptions and experiences within individuals' communities, such as participation in school activities, religious service attendance, social disorganization, and social capital. The SEM proposes that behavior is impacted by all these levels of influence, from the intrapersonal to the community, and that the effectiveness of prevention programs is significantly enhanced through the coordination of interventions targeting multiple levels. For example, changes in community-level social capital will create change in individual-level beliefs, such as perceived isolation, and changes at the individual or intrapersonal level are essential for changing communities. Our team is currently conducting a systematic review of the literature, examining the associations between social connection and opioid misuse. This review of the quantitative literature found several limitations in the current research. First, and most importantly, most of the studies included in our review were at high risk of bias. The most common limitation was sampling bias, as most of the studies relied on small, convenient samples, such as recruiting individuals from one substance use disorder treatment facility. We also found significant variability in measurement, both in how researchers operationalized social connection and how researchers assessed opioid misuse. The Surgeon General's report, Facing Addiction in America, was published in 2016 and highlighted research showing that social connection is associated with a decreased likelihood of substance use among adolescents and young adults. However, nearly all of the studies in our review that was specifically focused on opioid misuse were with adult samples. With few exceptions, study samples were overrepresented by white males, and none of the research examined the potential moderating roles of gender or race ethnicity. Finally, most of the research has been cross-sectional in design, making it impossible to disentangle the causal pathways. Despite these limitations, our review highlighted trends across the different levels of social connection and their association with opioid misuse. Overall, there was limited to no association between intrapersonal measures of social connection, such as loneliness or social isolation, and opioid misuse. In contrast, at the interpersonal level, we found both positive and negative associations with opioid misuse. In line with social interactionist theories, which conceptualize social connection as a necessary function to help individuals develop their identity, we found that social network characteristics, such as being deeply embedded within a network with opioid-using norms, was positively associated with opioid misuse. In contrast, when significant, perceived social support and connections with pro-social agents were protective of opioid misuse. And this is aligned with theories that social support may serve as a buffer for stressful events. For example, one study found that the relationship between adverse childhood experiences and prescription opioid misuse was lower among adolescents who felt they had a close relationship with their teacher. Generally, studies that use participation in community-level events, such as religious service attendance, as a proxy for social connection, did not find associations with opioid misuse. This suggests that these cursory measures do not tap into those theoretical constructs of social connection and the deep belongingness that individuals have with their communities. In contrast, while social capital was consistently associated with opioid misuse, the directionality of these associations was inconsistent. In other words, we found that social capital was found to be both a protective and risk factor for opioid misuse. Overall, the findings from our systematic review highlight the importance of both disentangling the umbrella concept of social connection and analytically assessing the interactions between these constructs. We believe this work can be informed by the extensive amount of foundational research which utilizes qualitative interviewing and ethnographic methods to tie social connectedness to opioid misuse. Such research focuses on a variety of social connectedness constructs, including the influence of community and economic variables, the effects of stigma and social norms, and the quality of romantic and familial relationships. These studies also place a great emphasis on contextualizing the experiences of marginalized communities and support the need for additional quantitative research to better understand the unique interplay of the multiple constructs of social connection. Next, you will hear from my colleague, Dr. Ty Ridenauer, who will discuss examples of how researchers across the country are implementing opioid misuse prevention programs that target social connection.
Thank you, Jessica, for your summary of the evidence, or lack thereof, on how social connections are linked to opioid misuse and disorder. Hello, everyone. It is a pleasure to present and meet with you today. I am Ty Ridenauer, and my presentation will begin by providing a high-level overview of the HEAL Prevention Initiative. It will then describe the aspects of this research that will address our gaps in understanding on the links between social connections and opioid misuse. The HEAL acronym stands for Helping to End Addiction Long-Term. HEAL initiatives were created in response to the ongoing opioid epidemic, which has yet to get through its third spike in overdoses, this time largely related to fentanyl use. One fundamental aspect of these HEAL initiatives is fairly unusual for NIH, which is to develop interventions that can immediately reduce opioid misuse disorder and overdose, including treatments and pain management. This type of emergency response to epidemics is traditionally relegated to the CDC. The HEAL Prevention Initiative, highlighted here, is funded through the National Institute on Drug Abuse and focuses on the long-term part of HEAL by developing the types of strategies that Dr. Graham referred to earlier. Specifically, this initiative involves advancing evidence-based interventions that are designed to deflect the developmental trajectories of adolescents and young adults away from initiating or escalating opioid misuse. The HEAL Prevention Initiative has included multiple funding mechanisms to accelerate research that will inform and develop interventions to prevent opioid misuse and disorder. 19 administrative supplements were awarded to expand ongoing projects to add research that pertains to prevention of opioid use. Most of the base studies of these supplements involve treatments that were then expanded in some way to focus on preventing opioid misuse and disorder. 2 pilot studies were also awarded. Lastly, the largest individual awards were to support 10 research projects to develop evidence-based prevention programs with the goal that they could be disseminated and implemented widely at the end of each study. As part of this effort, the Coordinating Center was awarded to support those 10 research projects in multiple ways, including leading investigations that span multiple research projects, such as understanding the role of social connections in the etiology and prevention of opioid misuse and disorder. To outline ways in which the HEAL Prevention Initiative will address the links between social connection and opioid misuse, it is helpful to organize their strategies according to the social ecological model that Dr. Kantz reviewed earlier. Their strategies fall along each of the concentric circles around the individual, from intrapersonal factors to community-level factors. Listed here are the 10 HEAL Prevention Initiative research projects with some minimal information. You can quickly see how distinct the projects are, even in terms of their settings, which span schools, emergency departments, single mothers at home, and persons experiencing homelessness. The developmental stages of participants also vary widely, spanning ages 16 through 30. Even so, one of the most consistent features across the studies is how many programs are designed to strengthen resilience against opioid misuse by strengthening the social connections of the intervention recipients. On the far right column is listed the social ecological levels where social interventions will occur. Collectively, they span all ecological levels and multiple programs more than one level. To illustrate the variety of interventions that are designed to strengthen social connections, I'll briefly describe 3 of them. One study led by Liz D'Amico and Dan Pickerson targets interpersonal connections among American Indians who are residing in urban areas. Their strategy is to reconnect participants with their native communities by celebrating and engaging them in healthy traditions and community activities. In addition, each participant maps out their personal network of social connections and evaluates the individuals in their network with regard to their risks related to opioid use and the healthy strengths of each of those associations. Motivational interviewing techniques will be used to encourage participants to intentionally make changes to their network to reduce vulnerabilities to opioid misuse. Some of the anticipated outcomes are social networks with fewer risk factors, healthier and more culturally grounded values, and greater native social connections, with the ultimate benefit of improved well-being, including emotional, physical, and spiritual well-being, and less opioid use. A second study is led by Danica Knight at Texas Christian University. This intervention is for youth who are aging out of residential facilities of juvenile justice departments. To reduce youth's vulnerabilities to opioid misuse, their intervention is delivered by Justice Department staff and is designed to strengthen a youth's attachment to and trust in an adult who is vetted as being safe and has an established relationship with that youth. The safe adult receives intervention to develop their skills in parenting or mentoring the youth, as well as enhancing the youth's pro-social connections. They expect that most of the adults will be a parent, but the adult could be another relative or some other associate. Intervention outcomes are expected to include enhanced emotion regulation, stronger social support systems, and more nurturing or family or mentoring relationships for the youth. In turn, these connections are expected to reduce the youth's vulnerabilities to and actual misuse of opioids. The third study that I'll mention is led by Laurie Palin, a pediatrician whose intervention targets intrapersonal social skills using a video game venue designed for 16 to 19-year-old students who are at risk for misusing opioids. In the game, a student's avatar has moved to a new high school and faces the challenge of developing social circles in this new school. The avatar must navigate real-life social situations, and the social decisions can earn or lose social cachet points. Additional opportunities are opened by making healthy decisions when the avatar is faced with scenarios such as being invited to join peers who will be using substances. The game scenarios, feedback, and rewards are designed to reinforce protective social skills such as self-efficacy in refusing offers to use substances and increasing the perceived harm of opioid misuse. To summarize, given the theoretical grounding of these studies, the scoring decisions of the reviewers of HEAL prevention grant applications, and the intervention emphases of the 10 projects that were funded, experts in the field appear to consider improving social connections to be highly important for preventing opioid misuse and disorder. This is in spite of the sparse evidence that specifically addresses these associations that was reviewed by Dr. Kant. The HEAL Prevention Initiative interventions collectively target all levels of social ecology and will encourage social connections of adolescents and young adults where these programs are eventually adopted. Based on preliminary evidence that was included in each proposal, we expect the HEAL prevention studies will yield multiple evidence-based interventions for communities to choose from in order to improve their efforts to curb local opioid misuse. Earlier, Dr. Kantz pointed out that one limitation of the existing evidence on the links between social connections and opioid misuse is the lack of systematic measures of both social connections and opioid use. Our methodology team will be working to fill this gap by developing such measures. Following these measurement advances, the planned mediation and moderation analyses of data from the HEAL Prevention Initiative studies are expected to provide additional insights into both the etiology roles and the prevention strategies that social connections play in reducing opioid misuse. At this point, I'll turn the webinar over to Dr. Elvira Ellick. So far, we've highlighted the importance of social connections in protecting against opioid misuse and disorder. However, in the era of COVID-19, we are learning a lot about the implications of physically isolating people from each other. Dr. Ellick will discuss the implications of COVID-related social isolation regulations for prevention programs that are designed to strengthen the social connections.
Thank you, Ty, for that nice handoff. So Dr. Kantz discussed the relationship of social connection to opioid use, and Dr. Reidenauer described the HEAL Prevention Initiative and provided information on social connection in HEAL Prevention Cooperative projects. I'm going to talk about the impact of COVID-19 on those projects, including how COVID-19 changed the format of interpersonal interactions and connections in the implementation and evaluation of their opioid misuse and opioid use disorder prevention strategies. I'm going to describe the challenges COVID-19 social distancing requirements posed for the HEAL Prevention Cooperative projects and how the projects adapted to those challenges, along with describing some of the silver linings that the projects experienced related to COVID-19. So first, for the challenges. HEAL Prevention Cooperative projects face competition with other priorities. In many of the contexts and organizational settings for the projects, COVID-19 caused decision makers to deprioritize substance use prevention as they took care of more immediate needs. Schools closed and moved to virtual education. Hospital healthcare staff focused on COVID-19 cases as emergency department visits for other causes dropped. And juvenile justice settings released youth early to reduce potential exposure. Each of these actions interrupted or changed plans for intervention implementation by the HEAL projects. COVID-19 also resulted in the loss of in-person interactions, including with regards to the recruitment of participants and providers, data collection, and other implementation aspects. The research projects can no longer recruit schools or other prevention providers in person. Recruiting participants for the interventions became more difficult when COVID-19 related consequences such as increased unemployment led to more mobility for the young at-risk parents for one study, or the earlier release of the juvenile justice participants reduced the transition window for another study. One study faced the challenge of needing to obtain parental consent and youth assent remotely when it was initially planned for an emergency department setting. And most of the studies had to switch to at least some virtual data collection, including for such activities as site visits and pre and post implementation surveys. That switch to virtual environments resulted in access challenges for participants and others. These challenges included many that you all have faced in the past 9 months with internet connectivity issues, but the challenges were especially acute in some of the rural communities and for some of the low SES participants focused on by the studies. Some of the participants had only cell phone access to virtual environments, or they had no access at all. Finally, COVID-19 related correlates and consequences also affected the studies. For example, concerns about higher rates of suicidality resulted in the need for increased monitoring and follow-up, as several of the studies included suicide risk within their measures. For another example, the increased participant mobility related to unemployment that I described earlier also made it more difficult to track participants throughout the study. The HEAL Prevention Cooperative projects adapted to many of these challenges, often using virtual and other innovative social connections. Several of the studies rely on their connections with their on-site partners to facilitate data collection and strategy implementation. This includes one research project which collaborated with their on-site partners to pull health record data, for example. To cope with mobility challenges and the lack of in-person interaction, the HEAL prevention research projects often utilized other methods and modes of connecting with their participants and maintaining communication, such as using phone calls and texting to keep up with them instead of using in-person visits. As I indicated earlier, restrictions on in-person data collection caused most of the research projects to collect at least some of their data virtually, such as by conducting virtual site visits over Zoom or switching to online survey data collection platforms. Now, when it came to actual strategy implementation, in some cases, the HEAL prevention research projects had already planned on providing virtual interventions, even before COVID-19, including with a telehealth parenting intervention and a portal follow-up to an emergency department intervention. Other projects had to adapt to COVID-19 and the related restrictions. For example, by taking an in-classroom intervention to virtual and hybrid settings, increasing participation in the telehealth portion of another intervention, and incorporating a video game intervention within newly planned telehealth appointments. One HEAL prevention project shifted from planned community settings for their events and instead used such methods as mailing food and sage to participants to hold native cooking classes and prayer sessions virtually. In addition to utilizing virtual interventions, some of the research projects had to look for other alternatives for specific subpieces of their intervention. In one example, one study assisted participants who were homeless with obtaining identification documents. When their local DMV closed and prevented them from obtaining IDs through that source, they instead moved to helping participants get birth certificates to use for identification for housing. And the research projects not just have to look for alternatives for their data collection and implementation activities for the project itself. They also needed to switch to virtual engagement of their community stakeholders, oftentimes moving to virtual community events such as town halls and advisory group meetings. I think at this point, we need to make an important point that these adaptations prove that when we use the term socially distant, we don't necessarily mean that folks lose their social connections. While they may have to stay physically distant from their community stakeholders, intervention providers, or participants, the HEAL Prevention Cooperative Projects strive to maintain the social connections that they find vital to their strategies. And a lot of the adaptations I just described prove just that. That also leads us to the fact that with every storm cloud, such as COVID-19, we usually find some silver linings if we look for them. One of those silver linings for the HEAL Prevention research projects is the opportunity they had to fill some of their partners' COVID-19 related needs. In some cases, the research project interventions provided their partners with options so that their partners could continue their work when they couldn't continue some of their other activities. In other cases, the projects provided their partners with the skills and knowledge needed to transfer their own social connection efforts to virtual settings. One research project switch from in-person implementation made them realize the comfort that youth and young adults have with virtual environments and the appreciation youth had for being able to participate in the activities in their own home. For any of those of you out there that have young adults or teenagers in your home, you could definitely attest to the fact that they spend a lot of time online. So that level of comfort with the online setting really helped some of the project participants be more engaged in the interventions that the HEAL Prevention projects were providing. Many of the research projects mentioned the convenience of the virtual activities for some of their community stakeholders, providers, and participants. This convenience issue is especially true in one area in particular, with activity participants not needing transportation or the travel time to get to activities. One project in particular indicated that the lack of transportation need and the move to virtual saved them a lot of money on Uber. At least one project also found that moving to a virtual setting helped them increase the geographic reach of their intervention. Originally planned for a few local settings within one state, the project received interest from community stakeholders and potential participants in other states, allowing them to also implement in those other areas. And again, all of that is happening virtually. And finally, the research projects in some cases address specific COVID-19 related concerns in their community. For one study in particular, the intervention helping homeless youth get housing likely reduces COVID-19 spread by providing those youth the opportunity to physically distance that they otherwise wouldn't have. So now I want to ask a question that I've somewhat answered with my examples, but I think we need more answers for. Can we make and keep the social connections we need for successful opioid misuse prevention intervention in a physically distanced world that we're currently facing with this COVID-19 crisis? While you think about that question, I'm going to pass the presentation back to Dr. Graham.
Thanks, Elvira. I want to thank everyone for participating today, and because we don't have a chat function where you can answer this question, we have another opportunity that might allow you to really think about and share with us. I'd like to invite each of you to an upcoming meeting that's a part of the annual meeting for the HEAL Prevention Initiative. And so on Wednesday, November 18th, we are having the third day of our annual meeting in which we're inviting the general substance abuse prevention field. And so that Wednesday is called Collaboration Between Researchers and Community Stakeholders on Evaluating and Disseminating Interventions to Prevent Opioid Misuse. As another incentive to consider registering, Dr. Nora Volkoff will actually kick off that day and really talk about issues around community engagement in this work. So you'll see on the screen, and it will be a part of the PDF, the registration. And so we do invite you to participate in some or all of the meeting, and then hopefully begin to share some of those ideas and thoughts and responses to the question that was just presented by Dr. Ellick. Again, I want to thank you for today. And at this point in time, I want to share the screen and move it over to Dr. Laurie Palin, who will actually facilitate and moderate our questions for this afternoon. Laurie, take it away.
Hi, so again, my name is Laurie Palin. I'm here to be your Q&A moderator today. I want to remind everybody before we get started with Q&A that we'll need for you, if you'd like to get CEU credits today, you need to stick around through the Q&A to get to your evaluation link and get your certificate. So please stick around with us, ask questions, and we'd love to have you as part of the discussion. Hi, everyone. We are monitoring the question box, and we'd love for you to submit some questions. Okay, so let's go ahead and start with one that we have here. So this question is for Dr. Camp. How can we improve the measurement of social connection?
That's a great question. The real key that we see is that we need to facilitate coordination across research projects. So for example, using the National Institutes of Health Phoenix Toolkit, that's a repository of measures across numerous domains, including social connection. And there are even scales that have been added on physical distancing measures during COVID-19. And so it would be possible, rather than creating your own measures of social connection, really trying to standardize and use what other studies have done, particularly if those measures have been used with similar populations. And when possible, we should be looking at multiple measures of social connection to see how they may be differentially impacting opioid misuse. Thank you for the question.
Thanks, Dr. Camp. So this next question is for Dr. Ridenour. So the question is, I work for a residential withdrawal management / detoxification program. Are there elements of the social environment within our facility that we could change to make it more conducive to recovery? Dr. Ridenour, are you there?
Hi, Laurie. This is Philip. Actually, let me take a shot at that. One of the things that I would highly encourage is, and reflected in some work that we've been doing for the Assistant Secretary for Planning and Evaluation around the use of social capital and social capital activities to really facilitate well-being within a variety of settings, including treatment settings. And what does that mean? As an example, we're really focused on things like creating cohort groups within recovery facilities that focus on, one, accountability, looking at the value of peer supports within those settings to, again, increase accountability. One of the things we'll do before we end today and put in the chat is some work we've been doing with ASPE that really talks about some best practices and principles around social capital development, as really understanding the social environment in which individuals who are in recovery can use as a way of kind of strengthening the way in which they proceed through your program. So thank you.
I'm sorry. Next question is for Dr. Ellis. What do you suggest to keep the important connections viable during COVID?
And that becomes the challenge. And it depends on what connections you're talking about. So if it's connections with youth and young adult participants, moving to virtual settings to do prevention is not the worst thing in the world. As we talked about in some of the examples in the presentation, there's some of these prevention providers are finding a lot of enthusiasm, and I've also seen that in a few other projects where youth are comfortable with the virtual environment. You may have to do things. So one of the tribal studies, the tribal focus studies that we presented on, they specifically are doing those community events virtually in a totally virtual environment, but making them really personable, whether it's, with sending the food, with sending the sage to them, doing things to really make the youth feel connected, even though it's part of this virtual environment. The other types of connections, social connections that you really need to keep to make any of your prevention interventions viable is those with your partners and those with your community partners. And I've heard some really creative things that people are doing with that, including, for example, one provider that I know participated in food banks to support one of their important community providers. And in the process of working on the food bank and supporting getting food distributed to community participants, they were also able to get their prevention messages out as part of that. So they were able to include normative campaign materials, for example, right in the packages that were provided to the community members. So there are things that you could do that both keep that social connection, but also get your prevention message out there.
Great. Thanks, Dr. Ellick. So the next question is for Dr. Kantz. Dr. Kantz mentioned that social capital can be both a protective factor and risk factor. Can you say more about the circumstances, sorry, my screen just hopped, in which it manifests as one or the other, and in situations in which it presents as a risk factor, what are the best ways to mitigate those risks?
Excellent question. I think this really starts to get at some of the limitations we have with the measures as well, in that individuals may feel very connected within their neighborhoods and within their communities. And so in traditional measures of social capital or more cursory measures, that may look like it's more of a risk factor because the individuals in their community who they are really connected with are individuals who are using substances. For example, we looked at one qualitative study where they showed for individuals who were misusing opioids, their closest connection was to their dealer. And so when you ask, do you feel connected to a person and to the community, that might not be somebody who is transmitting pro-social norms. And we see that in adolescence as well, that just because you're connected to a friend group or within a community doesn't necessarily mean that that's a protective connection. And so then what can we be doing in terms of prevention programs? We know that one of the programs, particularly within the HEAL Prevention Initiative, is actually looking at social networks and developing intervention programs to be able to talk with young adults about their social networks, so that you're really talking not just broadly about norms on substance use, but really helping individuals to disentangle the roles that their connectedness may be playing in their own substance use norms and behaviors.
Great, thanks, Dr. Kantz. So the next question is for Dr. Graham. I'm actually going to merge a couple of questions into one. So one of the questions is, are the interventions implemented by the HEAL approach, incorporated in a manualized format? And then related to that, another participant asked, was the Yale Avatar game developed to a point that it can be shared?
Okay. I'm going to answer those two questions and also just circle back around to our second attempt about there was a question to do the studies distinguish between SUDs and urban, rural, and suburban communities. The answer is yes. One of the really exciting parts of the HEAL Prevention Initiative is that there are 10 projects that are being implemented in multiple settings, which includes both urban, rural, and suburban. And we're more than happy to send you more information about that. That's really going to give us a unique opportunity to understand not only how interventions designed specifically for opioid misuse, how effective they are, but also effective in multiple settings with multiple populations. To answer the first question about manualization, that is a major part of this effort. What NIDA hopes to happen after these interventions have been evaluated, and for those that prove to be effective, is to quickly move to dissemination. And so in the last couple of years of the initiative, we'll be working directly with the 10 research sites to focus on issues like manualization. And so that at the end of this initiative, that we will be in a much better place to broadly disseminate both the findings and the ability to replicate and implement these strategies. That is the intent, that we think about how we effectively scale up and disseminate these strategies once proven to be effective for these populations. And the last question, so the Yale group is in the midst of development of their intervention. And so they are in what we call a 2-year UG3 phase, meaning that they are developing that intervention now. So unfortunately, it is not ready. And so for the most part, unfortunately, most of these interventions will not be ready for dissemination until towards the end of this 5-year initiative. As we learn along that path, though, we will be sharing learnings with the broader prevention field and community. So do look out for those opportunities of sharing that information and that data with you over the next couple of years. Thank you.
Great. Thanks, Dr. Graham. I'm going to direct the next question to Dr. Ellick. Have there been specific programs in this area targeted at young veterans? So very, very timely for today.
Within, like specifically directed at young veterans in the research projects that we're looking at, the HEAL prevention research projects, no. I am not directly aware of one, but I know I have heard of research going on in that area. So you definitely want to look into that, because I know that the military is specifically supporting research right now, both on opioid overdose prevention and on suicide prevention for that particular cohort. So if there's not stuff out there now, it's going to be coming out soon.
Great. Thanks, Dr. Ellick. This next question is for Dr. Kant. Social connection via technology has value, but doesn't come close to the actual human connection. What do you see as the most optimal or effective method for connection? And then they add, maybe I'm old school in my beliefs and need to find ways to ensure current technology has more value.
I think we're all feeling very old school in our beliefs at this stage. So I think what's really critical is going back to the theories as to why we think social connection is important. And one of those is, what's the difference between, again, surface level connection versus true, deep, meaningful connections. And so I think where the social connection via technology loses us sometimes is that you end up having a whole lot of screens, on your computer, so the Brady Bunch, as we often are calling it. And so you can't really talk with one another. And so one of the things that we've heard from other prevention providers in the field is actually doing like virtual office hours where students and faculty can meet one-on-one and be able to just talk and not have to have an agenda and just hear how you're doing, and make sure that you're building in the type of casual talk that you would normally be having in person, and making sure that that becomes part of the norm as well, that oftentimes when we're doing technology type of talk, we feel like we have to be more formal and it follows a specific structure. Trying to really treat it as more of a general conversation, being outside, not just being at your office desk. Those sorts of things can really shift and help us to feel more of that human connection.
If I may add to that, this is Philip Graham. To that question, I think we're also in an interesting place for natural observation. Because of COVID, we've been forced to really better understand the use of technology. And so one of the things that we hope that's going to be another learning opportunity for HIL prevention is the use of technology, in part because we've been forced to, and many of the research projects have had to pivot from how do you do community engagement in a virtual world, as well as intervention delivery. In addition to that, I think also we are attempting to really focus more upstream with younger populations who are much more comfortable with technology. And so we do think there is value there, but we need to test that out. And so again, one of the reasons I and the team are excited about this opportunity to partner with NIDA and these 10 research projects is to begin to answer those questions. And some of those we weren't intended to answer when we started this because the pandemic was not at the stage it is now, but we've incorporated that as a key aspect of moving forward. So again, we do hope to continue to share these findings over the next couple of years and really do a much better job of answering that question around the value of technology, when is it most appropriate, and with whom, under what conditions. Thank you.
Great. Thanks, Dr. Graham. So the next question I'm going to direct to Dr. Ellick. So, you spoke about a number of adaptations happening for COVID. So far, based on what you've seen, which adaptations to COVID seem to have the most promise for other research and program implementers? And could those adaptations be used in other types of crises?
And it's definitely the virtual that we've talked about. So moving to the virtual options, that's been the best responses to COVID. As folks have pointed out, it does, you think it might hurt your social connections. Sometimes it actually helps them. There's people that I've worked with that actually found like they were doing a lot of town hall type meetings in their community and insisting that they had to do those in person. And they actually found when they've moved those online, they got a higher number of participants that represented more different walks of life, who actually participated to a larger extent just because it was more convenient for them to be able to do it. So it's not, having to do these coping things, like I pointed out in the presentation, there's a lot of these silver linings that could come out of it, where you're actually increasing your connections with the communities in ways that you didn't think about because you were kind of set in how you were doing things before. I do have to say that you have to think out of the box. You have to have that flexibility. You really have to be creative in what you're doing with any of these. You have to have persistence. So if something's not working one way, you start doing a program online, but you're finding that it's more dry than it's in the classroom, for example, that you may have to add some more creative aspects to the program or pull in some more virtual aspects, whether it's using whiteboard features in Zoom to get the kids to interact with it. just getting them engaged, getting them in the program you're doing, that's probably going to be your biggest challenge with moving it to that virtual setting. Basically, it's also really important to be able to continue interventions in whatever format that you end up doing them in. Keeping those partnerships, helping them do things in the format that they provide for you to be able to do your interventions in. Making sure that you've worked on your partner relationships well before a crisis like this ever happens, because they're going to be the ones that get you into the communities and get you in with the participants that you have to be in with to be able to make any kind of adaptations in any of your programs to make it work with something like COVID.
Great. Thanks, Dr. Ellick. So we are getting close to the top of the hour. I think we have time for one more question. So I'm going to direct this to Dr. Graham. Aside from COVID-19, which is a big consideration right now, but hopefully we move past that soon, what are challenges to implementing interventions to increase social connections, especially for settings where these types of interventions are traditionally not used?
Great question. And speaking of questions, my team will probably start virtually throwing things at me. But I see one of the things that we will do is that we will take a look at the additional questions not answered today, and we'll work with our colleagues at the Opioid Summit to use today's mailing list to send responses out as well. Again, one of the things that we want to do as a part of the coordinating center is really inform how we think about prevention and prevention of opioid misuse in this space. And so these questions are valuable and important to us as we really understand how to better answer them. To answer that last question, yes. And so as we really try to better understand what social connections are, both those that are positive and negative, I think the development of interventions as mediators and moderators of this work means we have a lot to do. I think Jessica mentioned earlier as an example, social capital is a body of research that I've been focused on, but understanding that it's not just networks in general, it's actually positive networks. And so as an example, gang affiliation or delinquent behavior affiliation can create social capital, because social capital is access to resources and assets, right? And so we have to be careful about how we define what these topics are in a positive nature. But one of the other things that I also think that we have to begin to do is think about structural environments as it relates to social connections and how we facilitate the interactions between individuals and communities. And so there's a lot we need to learn. And one of the values of this particular initiative is understanding settings like juvenile justice settings, folks who are in child welfare systems, homeless youth. Those are systems that we traditionally do not work with. And so, again, we believe there will be tremendous learnings out of this initiative that NIDA is supporting, and really look at these non-traditional spaces and understand both the value of human interaction and how that serves as a protective factor with respect to opioid misuse. And again, as I said earlier, until we look upstream and until we understand those underlying factors and intervene on them earlier, we cannot stem the tide that's associated with opioid deaths and overdoses. So again, I want to thank each of you for taking the time out of your busy days to participate in this webinar. We look forward for continued engagement in the near future. And again, we do invite you all to that Wednesday, November 18th component of our annual meeting for another opportunity to share and learn more about what we're doing with our 10 partners and NIDA in this endeavor. So with that, I say thank you again and look forward to collaborating in the near future.